This presentation is on the 2014 to 2016 Ebola outbreak for MPH 5323. What is Ebola? Ebola is a highly contagious virus that belongs to the ortho-ebolavirus genus of the Filoviridae family. The natural host of the disease are fruit bats, and it can be transmitted to humans through their fecal matter or through the secretions of infected animals. The virus is extremely contagious as it is spread through any secretions from the body that can get into mucous membranes or open cuts. This can mean sweat, blood, vomit, urine, etc. The incubation period for the disease is 2 to 21 days, and the virus cannot be spread without any symptoms. The pathogen causes a wide range of symptoms such as fever, fatigue, muscle aches, sore throat, vomiting, diarrhea, rash, and internal and external bleeding, all which can eventually lead to death. The 2014 to 2016 outbreak of Ebola began in Guinea, and the index case was believed to be from a 2-year-old who was playing beneath a mangrove of fruit trees where fruit bats were nesting in Guinea on December 2, 2013. He then died 4 days later on December 6th. At this point in the outbreak, it was not known that the child died of Ebola or how it was spread from there. The virus spread throughout Guinea rapidly, and by March 14th, it was detected via lab tests and a national emergency was declared. The disease then spread to Liberia and Sierra Leone, causing massive outbreaks in these countries. Over the course of the next 2 years, these 3 countries were the epicenter of the Ebola outbreak. Although it is not the main area of the outbreak, it is worth mentioning that the virus spread to Nigeria, Senegal, Mali, Spain, United States, Italy, and the United Kingdom. Individuals from all walks of life were affected, both young and old, healthy and sick. However, there are subsets of people that the virus disproportionately affected. The first group includes healthcare workers and people who were in charge of managing the epidemic. They dealt hands-on with collecting ill individuals, transporting them to hospitals, tending to their illnesses, and burying the bodies. These individuals were significantly impacted by Ebola. The second group includes those who were close family members or village members. This is because the virus is spread via secretions, and individuals who were caring for a sick person with Ebola were exposed directly to the virus, making them more susceptible to the virus than those who did not deal closely with an ill individual. The third group of people were those who were involved in sacred burial practices. In West Africa, the belief of life after death is strong, therefore burial practices are seen as crucial to preparing the soul for the afterlife. They believe that if the body is not properly taken care of by family members, that the spirit will come back to haunt them after death. One of the common practices that caused Ebola to spread through burial is the washing and cleaning of the dead body, as well as washing the hands in a community bowl, then touching the face of the deceased. For some, laying over the dead body believed to help pass on spiritual gifts to the living. These are all burial practices that significantly contributed to the spread of Ebola. Lastly, individuals who lived near forests were disproportionately affected because of the occurrence of fruit bats and infected animals coming near individuals or touching the food and water that they ate and drank. Shown here is a general outline of the Ebola outbreak and response. There are several more key events that could not be fit into the timeline, so here are the most important events during the outbreak. On December 2nd, 2013, as mentioned previously, it is suspected that a 2-year-old boy contracted the virus while playing underneath a hollowed-out tree where fruit bats were nesting. 4 days later, on December 6th, 2013, he died in his village of Malandu in the Gekadu prefecture of Guinea. It is assumed that his close family members or village members caught the disease from him, sparking the outbreak. From there, the virus continued to spread and people continued to die. By March 21st, 2014, it was confirmed via laboratory diagnosis that the mystery disease causing all of the deaths was Ebola. Guinea officially declared a level 2 outbreak, prompting government response. By March 26th, 2014, the first case of Ebola was positively identified in Sierra Leone. By March 31st, 2014, the first case of Ebola was positively identified in Liberia. On April 1st, 2014, the Health Communication Capacity Collaborative, also known as HC3, dispatched. The HC3 is a USAID project that works to address social and behavioral change communications regarding public health crises. At this time, they were instructed to create instruction regarding handling Ebola and infection prevention trainings. By August 8, 2014, the World Health Organization declared Ebola a public health emergency of international concern. On September 16, 2014, U.S. Congress approved $81 million in funds to assist with the Ebola crisis, and they deployed military troops to West Africa. Over the course of the next year and a half, global efforts were given by nurses and doctors from other countries to help treat and manage the spread of Ebola. Through hard work, by February 2016, the end of the outbreak was declared in Liberia. By March 17th, it was declared over in Sierra Leone, and by March 18th, it was over in Guinea. By March 29th, 2016, the public health emergency was declared officially over. There were several barriers that contributed to the spread of the virus. The first was delays in recognizing cases. Because it was an unknown illness, it was being misdiagnosed as malaria, typhoid fever, cholera, and Lassa fever. It was not until March 21st, 2014 that laboratories identified blood samples as Ebola. Before the official diagnosis, there were 49 cases and 29 deaths. The misdiagnosis and delays in recognizing cases allowed for the spread of the disease because appropriate treatment and quarantine was not utilized. Another reason why the outbreak was uncontrolled had to do with the late government response from Guinea and the World Health Organization. There was a lack of funding and government resources in the country to facilitate an urgent reaction to the outbreak. Once the outbreak was known and the World Health Organization declared it a global emergency, it was too far spread to manage effectively with the resources present. By the time the World Health Organization declared a global emergency on August 8, 2014, there were 1,070 confirmed cases and 932 deaths. Lack of healthcare infrastructure played a large role in the delayed response to the outbreak. The countries affected did not have the hospitals, testing centers, laboratory capabilities, or staff members to manage the outbreak. When other countries came to the help, such as the USA and Great Britain, they had to build temporary hospitals and quarantine facilities in order to house the sick, take blood samples, and treat individuals. The reason the healthcare infrastructure did not exist was due to the country's low GDP, lack of modern medicine, and lack of educated individuals to manage any illness of this size. Lack of education and literacy in the population was another barrier causing the spread of the disease. There were significant communication barriers due to language differences and education differences, leading to the general public not understanding the warnings about the disease and being unable to follow directions. As I mentioned before, one of the largest events that affected individuals were the burial practices in the region. Being unable to explain that the burial practices were dangerous led to cases spreading rapidly due to the high influx of dead individuals from Ebola. According to a video by Frontline PBS, there was a large distrust in medical professionals due to a history of neglect and rapid influx of people from other countries who were supposed to be trusted. Rumors started that the medical professionals were killing the patients rather than the Ebola, and they should steer clear and even attack the makeshift hospitals and medical workers. All of these reasons contributed to the lack of control of the pandemic. The healthcare professionals during the outbreak relied on venipuncture blood samples from symptomatic individuals, and that samples were sent off to labs in other countries that could detect the Ebola antibodies that were present, or by using PCR to detect the virus. The samples were drawn in makeshift clinics, lab/hospitals, and then had to be transported 4 to 6 hours away to a laboratory, typically in another country, in order to be processed. The barriers to diagnosis included poor roads, lack of electricity in testing facilities, and the poorly functioning healthcare systems. The World Health Organization called for rapid diagnostic testing kits to manage the difficulties in testing. Therefore, a device called Ebola Check was created and distributed in May 2015, which allowed rapid detection of Ebola from one droplet of blood. 96 samples could be run at one time. Contact tracing was a large part of tracking the spread of the pandemic, however, it was very difficult. According to Swanson et al., contact tracing was only initiated for 26.7% of Ebola cases, and only 3.6% of new cases were discovered from contact tracing. The barriers that I mentioned on the previous slide had largely to do with the reasons why contact tracing was so unsuccessful throughout the pandemic. This graph shows the data provided to the World Health Organization through confirmed cases, contact tracing, and confirmed deaths from March 2014 to July 29, 2015. According to McNamara et al., Excel was the most commonly used program for tracing cases and reporting them to the WHO due to the lack of technology and programs available in the countries affected. Due to the large number of cases and lack of consistent reporting, the numbers were frequently incorrect, and it is likely that the numbers would have been significantly higher. The total numbers are estimated to be much higher. However, officially recorded, there were 28,652 total illnesses. The total number of deaths recorded were 11,325. These data were officially recorded, however, the numbers are likely not accurate due to missed cases, original misdiagnoses, late response to the pandemic, and insufficient tracking efforts. While specific hospitalization data are unavailable, many patients lacked access to formal care due to limited health infrastructure in the region. There were many lessons to be learned from this pandemic. It is hard to put any blame on the countries that it mainly affected due to their low income status. You cannot simply just make infrastructure better by wishing for it. You have to have money and resources. Therefore, it is the responsibility of developed countries to step in well before they did in this case. The World Health Organization has now developed an outline called Health Emergency Preparedness and Response, or HEPR. This outlines the goal of strengthening 5 core principles when it comes to pandemic and disease preparedness: collaborative surveillance, safe and scalable care, community protection, access to countermeasures, and emergency coordination. All 5 of these principles were failures when it came to the response to this pandemic. Secondly, acknowledging the culture and customs of a country when dealing with its citizens should have been improved. This included spreading information in local languages and at a level of general understanding, knowing about local customs such as the burial practices in the pandemic, to be knowledgeable about the effects of asking citizens to change their customs. Lastly, having continued access to countermeasures. In the case of Ebola, it took years to create a vaccine for it, and the vaccine relied on other more fortunate countries working together to advance science and research to come up with a treatment plan. Being prepared and ahead of research, as well as collaborating with other countries, will improve the response and treatment of another pandemic event. And here is the list of all of my references.